olmuş, bazılarında da olmamış. Bu da öyle bir grup ve yine bu
So electroconvulsive therapy, you probably know, there's people been investigating magnetic seizure therapy,
nöbet
which is a form
tedavisi de
of transcranial
yine
magnetic
transkraniyel
stimulation, but the
magnetik bir
goal
stimülasyon.
is to use the
Ama
magnetic
burada hedef
field
manyetik
to
alanı
induce a seizure
kullanmak,
as
bu
opposed to the
nöbeti
electrical
oluşturabilmek için
current that is
elektronik
used with ECT,
elektronik
and that is
bir
associated
akım
with much
vermeden
less
ifadede
cognitive
olduğu gibi
deficit.
burada amaç daha az bilişsel defisit
And
oluşturmak.
there's a way of trying to really focally administer
Fokal
the
olarak
seizure just to the
uygulanan bir
prefrontal
takım
lobe
nöbet
as
tedavisi.
opposed to the
Sadece prefrontal
disseminated
loba yayılması bunun.
ECT administration
Yaygın
currently done.
EKT
What I'm going to be mainly
konvülsiyonundan farklı
focusing
ama
about
aynı
today
yöntem
is
kullanılıyor.
all the
Benim bugün bu
subconvulsive
subkonvulsif
that I grouped them
yönlere
here, and you're going to be
odaklanmak
learning a lot
istiyorum.
of acronyms.
Bir sürü şeyler, akronimler var burada. Baş harflerin kısaltılmasıyla elde
cranial
edilmiş
magnetic
olan bir şey.
stimulation,
Transkranial manyetik
stimulation,
stimülasyon,
deep brain
vagus
stimulation,
sinir stimülasyonu,
and
derin beyin
epidural
stimülasyonu,
prefrontal
epidural prefrontal kortikal
As you can
stimülasyonundan
tell,
bahsedeceğim. Söyleyebileceğimiz üzere
we're going from non-invasively stimulating the brain from the outside with the transcranial magnetic stimulation, TMS, all the way to very invasive neurosurgery procedure where you're implanting the electrode in the brain and linking it to a pacemaker in order to achieve therapeutic benefit. And there's a wide range in between. And I'll take you through all of those with the kind of a punchline, because this is kind of a fairly abbreviated hour we have to cover all of this. But I've tried to kind of give you also what is common to all of those as opposed to what is specific. So if you put the brain depression circuit model up here, you can see that TMS would be accessing these circuits, so there's nothing magical about the prefrontal cortex by itself. But by stimulating the prefrontal cortex, we have access to this network. By stimulating with deep brain stimulation, we're putting the electrode in the limbic area, but again, the goal is to try to modulate the whole circuit. And with vagus nerve stimulation, it's really not brain surgery per se. You are putting the electrode around the vagus nerve in the neck,
sinirine
but making
koyuyoruz
sure that most of
VNS'de
the
de boyunda
information
ve
then go
bilgilerin
upstream,
birçoğu yukarı
and then
doğru
it's
gidiyor
gonna
buradan
modulate
ve
the
ondan
system.
sonra yine bu
Just
depresyon
make sense?
kısa devresini modüle etmiş oluyoruz. Bu size mantıklı geldi mi?
And if you put them in terms of continuum of how they're likely going to play out therapeutically, obviously it's still much easier and probably less costly
ve
as
muhtemelen
well
daha
as
az pahalı oluyor.
easier to
Maliyeti daha az maliyetli
disseminate to
oluyor.
give
Hastaya bir sürü
But
ilaçlar
as you start
vermekten
moving
daha
in terms
bazı
of
açılardan
either
kolay.
treatment resistance
Ama tedavi
continuum,
rezistansının
so the people
devamlılığı
that are
bakımından
failing
izlenecek olursa
antidepressant,
antidepresanlar
you might
açısından
find that, starting with TMS would
TMS
still
ile
be a
çalışmak
much simpler,
yine
easier,
oldukça basit,
non-invasive
kolay,
way to do
non-invazif
things.
bir şey bunu
And it
yapmak
can go all the
bakımından.
way to deep brain
Ve yine
stimulation
derin
in
beyin
terms of having to
stimülasyonuna
have
kadar
a
gidebilirsiniz.
neurosurgery
Yani bir beyin
procedure
cerrahi
to
prosedürü
treat someone.
gerçekleştirip bu
So
hastalara
they're
tedavi
not
etmek
all
amacıyla bu arada
equal.
gidip geliyorsunuz. Bunların
It's
hepsi
just a
birbiriyle
question
eşit değil
of also,
elbette.
and when you
Ama
give them,
ne zaman
it's
neyi
going to be likely
verdiğiniz
function
önemli,
of
hangi
how treatment
fonksiyon
resistant
ve
the
tedavi
patient is
rezistansının ne
how
kadar
many have
olduğu
they failed
hastanın
before.
ve nasıl olduğu ve daha
What
önce
I've
neden
highlighted
başarısızlıklar
in
olduğunu
blue
bilerek
are
yapmanız
the
lazım.
ones that are
Mavi
still
ile işaretlediklerim
investigational.
hala araştırma altında olanlar, hala
Vagus nerve
araştırmalı olanlar.
stimulation got
Vagus
approved
sinir
about 3
stimülasyonu
years ago
3
in
yıl
the
önce
United
onay
States
aldı.
for,
Amerika Birleşik
by the FDA
Devletleri'nde
for treatment of
FDA
depression.
tarafından
I'm going to show you the
onaylandı.
data that got
Bu
it approved.
konudaki
Obviously,
dataları size
ECT been in
sunacağım.
practice for a
EKT
long
zaten
time,
çok uzun
and
süreden
TMS
beri
actually got
yapılmaktaydı.
approved in the
Ve
United States
TMS'de
for
Amerika
treatment of
Birleşik
depression by
Devletleri'nde
the
depresyon
FDA
tedavisi
back in
için
October
FDA tarafından
2008. So that's
Ekim'de
fairly recent.
2008'de onayını aldı. Bir oldukça yakın
reason
zamanda
why
olmuş bir onay bu.
brain stimulation might work
Beyin
is really,
stimülasyonu
again,
neden
if you
işe
collectively think
yarayabilir?
of these
Çünkü
networks
kolektif olarak
as
düşünecek
not
olursanız buradaki
functioning
ağı
properly
uygun olarak çalışmayan bu ağ
and not being effective in in communicating with each other, then the way to stimulate the brain would be a way to kind of reorder a certain harmony between these networks and get them to be a little bit more in sync and better functioning.
daha iyi
So the
fonksiyon hale
idea of
getirebilir.
stimulating a
Olmak
specific
için yapılan bir
network
şey bu.
is to try and
Bu
get
spesifik
it back
network
into
stimüle
kind of a more
edilerek daha
functional
fazla
mode.
fonksiyonel bir hale getirilmeye çalışılıyor.
And ultimately, if we
Ve
were
sonuç
to
olarak eğer
make a lasting change, what we would need
sürekli
to
olacak bir
also
şey yapmak
invoke is a
istiyorsak
change
yine
in the
bunu
plasticity of the system,
sistemin
so that we can
plastisitesini de
essentially
değiştirmemiz lazım
be
ki
able to
ondan sonra
it keep fading.
Sürekli olarak
It will be able to kind of make long-term changes in the synaptic plasticity system, so that the resilience that I was talking to you about might actually be enhanced, and patients would have less possibility for relapse. Let's start first with the transcranial magnetic stimulation. It's the least invasive, actually it's non-invasive form of doing TMS, and the principle is fairly simple. You have a battery that charges electricity. The electricity goes through the coil. It generates so the electricity goes through the coil. It generates magnetic field that goes unimpeded through the skull and tissue. It will depolarize the neuron, and you're going to have a behavioral output. So, in other words, if you expose a neuron or a brain tissue to very rapidly alternating magnetic field, a little bit like the MRI. With the MRI, you put someone in there to get a brain picture, for instance. The magnetic field in the MRI are about 20,000 times the Earth's magnetic field. So they're very high, 1.5 Tesla or 3 Tesla. The difference between TMS and an MRI is that the TMS changes very rapidly the magnetic field. You go from 0 to 20,000 times the Earth's magnetic field in a split of a second. With the MRI, the field strength is constant. It's really that sharp rise that induces electrical current in the brain, and then you have a neuronal depolarization. This is a very critical point to why TMS would work, and let's say an MRI is not necessarily a therapeutic mode. There's a number of TMS manufacturers, and I have them listed also in your handout. In my mind, all TMS technology is equal. Some of the design of the coils and the stimulators are a little bit different across the manufacturer, but they essentially are all based on the same principle. The one disclosure that I need to do that I'm going to be talking to you about the data from the neuronetic trial, and the neuronetic trial is the only TMS approved device for treatment of depression. Let me see if I can play this movie for you. I thought I had. I think it'll be a good way for.
İyi bir yol olacak.
Ama 5 dakika sonra alayım istersen, şimdi de alabilirim.
Yok. Oynatıyor, tamam. Yok iyiyim ben.
5 dakika sonra.
So there's a TMS over the motor cortex, and every time there's a click, you probably don't hear it. Click.
Yani duymuyorsunuz, orada bir klik sesi
kind of
var. Her klik
the
sesi
motor contralateral motor
kontralateral motor depolarizasyonunu gösteriyor. Her klikte bir kas hareketi oluyor.
So that's how you essentially dose TMS, because every person has a very different.
Her kişi farklı
motor threshold. And this is a train of stimulation. This is
bu stimülasyonun sesi.
So essentially, it's just the clicking noise of what you're hearing with the stimulation. To recap, you dose the TMS by stimulating the motor cortex because there's only very few spots in the brain where you can stimulate and you can see direct effect of the TMS. If you stimulate directly over the prefrontal cortex, there's no observable phenomenon that you can dose TMS with. And so we put it over the motor cortex and you increase the intensity up until you see a muscle twitch. And we assume this is the level of energy we need to deliver to depolarize the neuron in one particular subject. Then we would move forward to the prefrontal cortex, and instead of stimulating one pulse, we give trains of stimulation like I just showed you, which is a session of typically about 35-40 minutes, and it's a daily treatment, 4 to 6 weeks in general. And you notice that one thing that is very unique about TMS in this context is that the patient were very alert. He was sitting, he could drive in, drive out, so it's really not like what might be going on with ECT, where you have to have someone under general anesthesia and then have somebody drive them in and drive them out because they just recovered from being unconscious and having a seizure. So it's a much more tolerable phenomenon. The earlier studies that did try TMS were kind of underpowered in general, and we've learned that with more pulses, with higher intensity of stimulation, and with more number of sessions delivered, we can actually reach better benefit. And so that particular information is what informed, this was kind of between the mid-90s to the early 2000s literature. And what happened is that at that time, there was a design of this study that ultimately got FDA approval, where essentially you took treatment-resistant depression patients and you enrolled them in a double-blind, placebo-controlled TMS study without any medication on board. So all of the patients were taken off any antidepressant they had, and they either got daily sessions of TMS for 4 to 6 weeks, or placebo. If they improved, they went on to a maintenance treatment. If they didn't, they crossed over and they got offered the real treatment. And the bottom line is that TMS was more effective than placebo at 4 to 6 weeks in reducing the antidepressant effect. And when you look at the categorical outcome in terms of the efficacy of TMS, you can see that by 4 weeks you had a distinct separation on a categorical outcome of 50% improved from the placebo. At 6 weeks you had the same kind of differential. However, what is really interesting is that at 4 weeks you have essentially no distinction in the remission rate, but at 6 weeks you did have a difference in the remission rate. So by 4 weeks you were on the way to responding, and you had hit the 50% cut, but you had not gotten to be symptom-free. To put this a little bit in context, there was a really interesting meta-analysis done by Kahn, where essentially in the United States, under the Freedom of Information Act, he was able to go to the
özgür bir şekilde
FDA and
paylaşılması
ask for all
sonucunda
the
FDA'ye
studies
gitti.
that were
Bütün
deposited by
çalışmaları pozitif
pharmaceutical trials
farmasötik
to
çalışmalardı
get
bunlar.
an
Pozitif sonuçları elde etmiş
antidepressant
olan antidepresan test edilmiş olan bütün
there were some
antidepresan
positive
sonuçlarını
studies, there were
aldı.
some
Bazı
negative
pozitif
studies. He was
çalışmalar
able
da
to
vardı,
pull
negatif
all
çalışmalar da
those
vardı.
and run a meta-analysis
Ve bir
on them.
meta-analiz
And
gerçekleştirdi
essentially the
onlarla.
effect size that he
Ve buradaki
computed
etki
out of these
boyutu
studies, so
bu çalışma
the net
içerisinde
benefit of an antidepressant versus the
antidepresanların
placebo
yararıyla
drug
placebo
across
ilacının
these
yararını
large
birbiriyle
pool of
karşılaştırdı ve çok geniş bir
study is
meta-analiz
about
havuzunda bunu
0.49,
yaptı.
which is a fairly
0.49.
modest effect
Oldukça
size. It's not
ortalama
very
bir
dramatic in
etki
terms
düzeyi bu
of
esasında. O kadar
the
dramatik
active
bir şey
versus the
değil
placebo,
aktif ve placebo
but fairly modest,
karşılaştırıldığında
and
bakacak
that typically
olursanız. Bu
is
ama
what you expect
tipik
with all the
olarak beklediğiniz
antidepressants.
şey
And this is
esasında herhangi bir
typically is for
antidepresandan.
treatment non-resistant
Bu
patients, because most
tedaviye
of the
rezistan
antidepressant
olmayan
drugs that got approved on
hastalar
the
bunların
market
birçoğu.
have been tested in first episode
İlk
or treatment
epizotlarda
naive
veya
patients
daha önce hiç tedavi
more often
almamış olan
than
hastalarda
in
yapılıyor
treatment-resistant
genellikle
depression
farmasötik
cohorts.
çalışmalar.
And
Onun
if
için
you put
bunlar
the
genel olarak
context
tedavi
of
rezistans
what
hastalar,
the
rezistans
TMS
göstermiş hastalar
study
değil.
effect
TMS
size is
çalışmasındaki
roughly in the same
düzey
kind of
aşağı
ballpark
yukarı
than
aynı
this
tür
large effect
bir
size of the
düzey bu etkinlik
pharmacological
genişliği
trial.
bakımından bakıldığında.
However, if you
Bununla
just take
birlikte
the
nörosar
subgroup of
çalışmasında
patients
bir alt gruba
that had
bakacak
failed
olursanız
one
daha önce bir
antidepressant
antidepresan
treatment in
alıp
the current depressive
başarısız
episode
olunmuş
before
ve şu anda
they
var olan
received
depresif
TMS,
epizotta olan
you
hastalara
have a very,
bakıldığında
very
çok
robust
belirgin
effect size
bir
that is
etkin
almost
etki
the
boyutu
double of
görülüyor.
what you
Neredeyse
see
2
with a
kat
drug.
fazla
Keep in
olmuş
mind
ilaçta
that here the average
karşılaştırıldığında. Buradaki
population
ortalama
is
popülasyonun da
about 1.6 failed
1.6
antidepressant trials
antidepresan başarısızlığı
coming
göstermiş
into the
olan
study.
hastalar olduğunu
So they
bilmemiz
had
lazım.
failed on
Bunlar genel
average
olarak tedaviye
1.6
daha dirençli olan
full
hastalar.
dose of an
1.6 kere full dose antidepresan almalarına
drug
rağmen
before they got into
başarısızlık
the
görülmüş
study.
tedavilerinde.
And
Hastalar
here,
alınmış bu
you took
çalışma
one
grubuna
subset
ve
of
bunların
each
altından da
patient,
bir
which is
grubu
almost about
aldığınız
2/3
zaman
of the
bunlarda
patients in the study
çalışmadaki
were
hastaların
essentially
neredeyse
they had
2/3'ü
failed one.
bunlarda da en az bir antidepresan tedavi başarısızlığı görülmüş.
Cognitive
Onlar
side
da
effects
TMS
are
oldukça
really
başarılı olmuş.
non-existent with
Bilişsel
TMS.
fonksiyonlarda
Unlike what
TMS
you
ile
do
herhangi
with
bir
the
değişiklik
ECT,
görülmez.
you
Halbuki
might have
EKT ile
little
bu
bit
çok
of
belirgin bir şekilde
mild
görülür.
changes, actually
Bir takım
positive improvements, but we
değişiklikler
think these are much
olabilir,
more
pozitif
attributable
iyileşmeler
to essentially
olabilir.
the antidepressant
Esansiyel
effect
olarak
and the
antidepresanın
improvement of
etkilerini
cognition following the improvement
bilişsel
in the
ve
mood rather than
iyileşme
TMS
süreci
makes you
içerisinde
smarter.
TMS'nin hastaları
And
biraz daha
this is an illustration really of a case report that I
iyi
published
yaptığını söyleyebiliriz bu açıdan, yani bilişsel
10
fonksiyonlar açısından.
years ago,
10
where in
yıl
fact,
önce
when we first started doing TMS research,
TMS
the
araştırması
FDA
yapmaya
had not
başladığımızda
put a limit
FDA bir
on
sınır
us being
koymadı.
able to enroll women
biz
who are pregnant.
Gebe olan kadınları da
In one
çalışmaya
of our
almıştık
clinical
o zaman.
trials,
Bizim
we
klinik
had a
çalışmalarımızdan bir
presentation of a woman who
tanesinde
was an IBM
bir
executive
IBM'de yönetici olarak çalışan ilk gebeliğindeki bir kadın, 36 yaşında olan bir kadın da çalışmaya alınmıştı. Çok ajite bir şekilde, çok depresif bir şekilde karşımıza çıkmıştı. Hamilton skoru çok yüksekti ve Hamilton anksiyete skalası da çok yüksekti gördüğünüz gibi 40.
Çok dikkatli olmasını söyledik. TMS'yi so we actually randomized her to either active or sham, but she turned out to have received active from the beginning.
Daha başından
And
beri
you can see
aktif
here these
aldığı
are
ortaya
on
çıktı bu
black
hastanın.
every session of TMS she
Bu her
received.
TMS
When she
seansını
first came to
gösteriyor
see us, we were
bunlar.
kind of a little bit
İlk
hesitant, so we
önce
asked her to
biraz
kind of just go seek some counseling and try to get
bize geldiğinde
this
biraz
resolved
çekingendi.
somewhere
Onun
in
için
a
bir takım
different fashion than through
farklı
research.
bir
And she
araştırma
had
açısından da
dropped 7
tavsiye almasını
pounds. She was
söyledik
really
ama
doing poorly. We finally randomized her, and with
7
treatment she
kilo
became better. She was
7
gaining
pound
her weight
kaybetti,
again.
yani yaklaşık
Her
3 kilo
anxiety
kadar
dropped, her mood
kaybetti.
improved, and she
Ama
became
en
really
sonunda
symptom-free and was
modu
able to
iyileşti
deliver a
hastanın
baby,
ve
you know,
bir bebek
by end of
doğurabilecek
her
kadar iyi
term.
bir hale
And it
geldi.
was a really
Gebeliğe
nice
sperme
illustration
geldiğinde oldukça iyiydi. Oldukça
of
güzel bir illüstrasyon olduğunu
what
görüyorsunuz
TMS can
bunun.
do
TMS'nin ne
in a
yapabileceği
context,
konusunda.
in a clinical context
Çok
where
ilginç
you really
klinik bir
don't want to
yapı
introduce a drug
içerisinde
that
gerçekten
might have
bir ilacı
interaction
verseniz bir
either
takım
with the baby in
etkileşimler
this
olacak.
particular
Bu
case
özel
or
vakada
some of
bebek
the the elderly where you really worry about drug-drug interaction or other kind of topics. So although the approval is now for non-specific, I think down the road you're going to see more and more specific application of TMS in kind of a subset of population where you want to see if you can avoid using a drug or you clinically are at an advantage of avoiding adding another drug on board. I will bring up to you one other illustration of TMS because I think the impact of it is going to be fairly important. This is a colleague of mine, Jeff Borkart, and he's interested in researching pain and brain stimulation. And what he did essentially is that he went to patients who were not depressed, were getting a gastric bypass surgery, and essentially went to the recovery room right as the patient were coming out of surgery. He had consented them before, and in their recovery, he gave them only one session of TMS, about 45 minutes, or placebo. And what he used as a primary outcome measure is not just simple subjective rating of their pain after the surgery, but used how much morphine they ended up self-administering through the PCA pump over 48 hours, which kind of makes it a much more objective outcome measure as opposed to asking your patient, are you in pain or not? And what he found is that a single session of TMS reduced the use of morphine significantly by 40%. So if you think about it, and this is kind of a very interesting because what happened is these patients were not in chronic pain. They were kind of a normal patient who had a very painful procedure. The pain system in the brain were very active right after the surgery. And at the right moment, he was able to stimulate and had a net reduction of the use of opiates, which really translate to quieting down much of that pain system in the brain that kind of reactive after the surgery, which is kind of a very interesting way of beginning to look at that. And if you think about it in terms of health economics, when patients go to their dentist or they get a back injury and they've never really been addicted to opiates and they start taking some pain meds and now all of a sudden a percentage of them flip into addiction. If we can think of brain stimulation to reduce the use of those in these acute procedures, we might actually be able to have a large impact on the chances and the percentage of patients that actually end up moving from acute utilization of opiates and analgesic to essentially addiction. So it's another really interesting, novel way of thinking about brain stimulation. So that's for TMS. For vagus nerve stimulation, it's getting a little bit more invasive, obviously, because here you have a pacemaker that is wrapped around the left vagus nerve. And the unique thing about the vagus nerve is that if you think about the direction of the fibers, 80% of the fibers in the vagus take information from the periphery to the brain. Only 20% control heart, lungs, and GI. We think about the vagus nerve more like when I went to medical school, most of what I've associated the vagus nerve stimulation is peripheral control of heart, lungs, and GI. But that's really 20% of the fiber. Most of the fibers are going the opposite way. They're taking information from the body to the brain. And by wrapping the electrodes in a particular direction, you're essentially making sure that the induced electrical current are going upstream, and then get into stimulating the circuit. And so this is the first bus stop is the nucleus tracts solitarius, and then you go to the locus ceruleus and the raphe, and then from there on to obviously all the limbic system and the prefrontal system, which are the projection of the nuclei. And if you layer on top of that the model that I was telling you about, you can see how you start getting into these specific networks that are important in mood regulation. This is how the pacemaker looks like. It's kind of a fairly small and fairly thin. The first generation of pacemaker were much thicker, but now they're fairly thin. And these are the electrodes that are wrapped around the neck. And the way you control it is the way you control any heart pacemaker with a wand. And so you kind of put the wand over where the implant battery is, and with a PDA you can program the setting in terms of duty cycle, intensity, and so forth. The first approval for VNS has been for epilepsy. This is data over 3 years, and you can see that it takes a while for you to recruit response. So over essentially 1 year, 1 out of 3 has responded, and by second year, you're about 43% response in terms of the average seizure reduction. What was really interesting is that it turned out that in these patients, there were mood improvements that were independent of the seizure control. So there were noticeable changes. Actually, one of the hotel clerk in one of the study sites where most of these patients were coming in to stay overnight, so they would go into the hospital the next day to get checked by the epilepsy group researching VNS, had made a comment to one of the PIs, like, I don't know what you're doing to these patients, but they look happier to me. It's really one of the first anecdotes of finding an independent mood effect from the seizure control. Not all the patients that mood was improved, and then this was tested retrospectively and then prospectively, had a reduction in their seizure, but there was an independent mood. And there, if you think about it, in our treatment, ECT is an anticonvulsant. We use anticonvulsant frequently as a mood stabilizers, as lamotrigine has both an antidepressant and a mood stabilizing property. So the interplay is not necessarily so far outreach. There have been several studies. I'm going to take you to the most critical one with VNS, in which the comparison was either vagus nerve stimulation plus treatment as usual. This is a long-term study. So patients were implanted with VNS. First, they got randomized to placebo or active just for 3 months without changes in their drug, but after the 3 months, a lot of changes could take place, including changing antidepressant medication. And there was a cohort group that was essentially just patients who were being followed in the community just as treatment as usual. What I want to point out to you is something very important, which is essentially here at the bottom. I don't know if I'll read it for you, but essentially the average failed response was about 3.5. So again, when you look at the STAR-D data, you're expecting no one to respond at this level of treatment resistance. Because it's not like you failed 1.6 like the TMS data that I showed you, or you hardly failed any like most of the antidepressant drug trials that got them approved on the market. You're talking about a very treatment-resistant cohort, and almost a third of the patient had tried ECT in a current depressive episode and failed it. 50% of them had tried ECT at one point in their illness. And you can see that the average duration of the illness has been about 25 years, with almost 4 years of the current depressive episode. So very sick. The acute data was negative, and this is the controversy behind vagus nerve stimulation. I think in part because we underestimated the time it takes for VNS to kick in. If the primary outcome measure was at 4 months instead of 3 months, it would have been significant. Nevertheless, this is a negative data, 15% response, 10% response in the placebo. If you think about also in terms of what is informative here is that 10% of response in the placebo is a third of what you typically see in any clinical trial with depression. Typically, the average response of placebo is about 30, if not higher. So very sick patient. But we get the same phenomena that we saw with the vagus nerve in epilepsy, that over time, you start recruiting more response. And by 1 year, you went from 15% to 30% response. And if you compare the two groups, the one that had VNS plus treatment as usual versus the cohort that was just treated as usual, the punchline is that at 1 year, you have 1 out of 3 chances of getting better with VNS added to your treatment than treatment as usual alone. And you have doubled your chances from treatment as usual. The treatment response here is about 12%. The treatment response is about 30%. So essentially, you're doubling your chances, but you're unfortunately still 1 out of 3 to be approved. What is unique about VNS, and this is, we're talking now years, 1 year or 2 years of continuous stimulation, is unlike anything else we have seen in terms of our treatment. And remember the slide that I showed you about the relapse rate. The people who respond to VNS acutely, 2 out of 3 are holding their responses at 1 year and at 2 years. Whereas with ECT, 2 out of 3 would have relapsed within 6 months. So it's kind of a very unique way. We still don't fully understand the mechanism behind it. But one of the things we've done is we've done serial functional imaging and have shown that really, if you think about this network that I was highlighting to you as the critical in modulating to get an antidepressant response, what is more important with tapping into this network when VNS is firing is really function of time. The more you're able to expose the brain to this intermittent stimulation, the more with time the stimulation was able to take it to the right place. There have been a lot of problems. Part of it is the controversy over the data that it had not made VNS widely disseminated. There's only been about 3,000 since the approval in 2005. But that's a whole story on its own, and I'm happy to entertain any questions. For the sake of time, I want to take you briefly through the epidural and the DBS data. We have about 10 minutes. The epidural cortical stimulation I mentioned yesterday in my plenary lecture. The idea here is to implant the electrode on the surface of the cortex. This is an example of the electrode where you would have 4 contacts, and you can program them either positively or negatively, and you can change different frequencies. The variability of stimulating parameters are very large. But again, the idea is to try to hook those to a pacemaker, and in our study we were interested in looking at bilateral stimulation, and so we ended up implanting 4 different electrodes. And this is a schematic again of accessing the network. One of the reasons why I wanted to go with lateral prefrontal as well as anterior pole is, as I explained yesterday, I think these are 2 complementary networks about engaging with the world as well as being interoceptive and modulating mood specifically and self-other relationship. And so we were able to essentially study these different dimensions, and I'll show you some of the data in a minute. The surgery is done stereotactically, so if you pull up a patient's own brain and you had essentially pre-highlighted the area of your interest, you can use cameras in the OR to really yoke the brain in space to the pictures in the computer, and then being able to do a much more accurate targeting. And this is again, it's a burr hole. It's a very small burr hole on each side, about 1 by 2 centimeters kind of wide, and it's typically done behind the hairline, so the aesthetics of seeing this, and then you slip in the electrode further down. So the burr hole is really behind here, and you're kind of slipping down the electrode epidurally. We did in the OR testing, so the patient was had awake during this procedure, and what we did is we stimulated on-off at different parameters. The patient were blind to the stimulation, and you can see that with stimulation we had increase in attention, and then it would go down when we stopped the stimulation, as well as improved kind of a feeling settled and emotionally relieved, which was a very striking phenomenon to see, especially in patients where the average failed treatment coming into the study was almost 6. So we're talking extremely severely treatment-resistant depression of 6, as opposed to the vagus nerve stimulation, which was 3.5, the TMS, which was 1.6, and most of your drug trial, which are 0, essentially. And so this was kind of a positive first indication. We only have 5 patients so far, but again, I'll show you this to kind of to go for speed. But again, we have 3 remissions after the acute phase so far. This is a very treatment-resistant bipolar patient whose last depressive episode was 5 years. He had failed VNS, as well as ECT, as well as TMS, as well as ketamine infusion, as well as glucocorticoid. I have given him mifepristone, which is an RU486. I have tried a lot of combination, including monoamine oxidase inhibitors, and essentially it took a while for him to respond, but then ultimately went into a remission and not hypomania. He recently relapsed, and we're trying very aggressively to get him back. 2 notes on the deep brain stimulation. Deep brain stimulation is obviously implanting the electrode deep into the brain, whereas there's about, now the numbers are close to 50,000 implanted cases for Parkinson. When it comes down to depression, there's less than 50 implanted. So there's a lot of interest about it, there's a lot of publication about it, but really the numbers are still fairly small. And what we're doing with DBS, there's been reports there's been report about trying to stimulate either the subgenuine cingulate. There's been report about trying to go into the internal capsule, the interior limb of the internal capsule, and there have been reports about stimulating the nucleus accumbens. All of these circuits are involved in mood regulation. There are open data, they're promising data, but none of them have been controlled double-blind placebo. And what is going on right now is that there's 2 different companies trying to investigate two different targets. One is the stimulation of the subgenual cingulate Brodmann area 25, and the other one is the anterior limb of the internal capsule nucleus accumbens target. And these studies are starting to, they started recruiting for them in the United States, two different companies trying to go after FDA indication, but the results are not there yet because the study have only begun. We've done animal work with deep brain stimulation in animal models of depression and have shown that essentially 24-hour stimulation of DBS, if you add to it an antidepressant like dipramine, has a synergistic effect. In our model, DBS by itself was not better than fake treatment or placebo. The dipramine was marginally effective. That's because we had subjected the animals to a much higher level of stress for 21 days before we tested them. But the unique part is that we've actually found synergistic effect with the antidepressant, and we're continuing to refine the research on that aspect. I talked to you a little bit about neuroplasticity, and essentially what we've shown is that our animals do essentially under stress reduce the BDNF in the hippocampus. They also increase BCL2, but let's focus just on the BDNF reduce without stress. So these are the type of animals we actually implanted with DBS to try and test the antidepressant effect. And then when we look at the outcome and the protective effect, you can see that 24-hour stimulation of DBS doesn't do much than placebo or sham stimulation. But if you continue for 7 days, after a while, you start getting a protective benefit. So the idea, again, with brain stimulation, that what you need to think about is that it's also time dependent. So the more you stimulate, there's an adaptive phenomena that is taking place over time. And my last slide for today is essentially to talk to you that although I had introduced this notion of the network, and I've introduced the notion that we can tap into the network from different points of entry. At the end of the day, if we were to induce a change, a therapeutic benefit, it's likely to be in a common network, where most of what we've shown so far in our studies of brain stimulation have shown that the common denominator is this kind of medial and some of the lateral prefrontal cortex network. This was my last slide. Again, sorry we're running we ran a couple of minutes late. But if you have any time for questions, I'm available. I'm happy to add.
Memnuniyetle cevap vermeye çalışırım.